Look who's there. It's Dr. David Rosensweet. Good morning.
Good morning, Carolyn.
It's really nice to see you.
You too.
Always. Greetings as we do. Questions are coming. I'll welcome in everybody who's going to be coming up. Lots of new people and a lot of men too, which is pretty exciting, I think. Good questions. Shall we start?
Sure.
All right. So, question number one comes in. This came in from a gentleman in regards to his wife, who he's very concerned about. She is 40 years old, and she's menopausal, obviously. Her physician has put her onto a testosterone gel only due to his concern about her having endometriosis. So her doctor wants to watch her and then add in slowly progesterone and then estrogen, micronized progesterone and then estrogen. It's a little bit confusing, he says, to us, and we're wondering what your thoughts are in regards to this kind of going backwards, like he feels. She's having low libido, vaginal atrophy, low mood, many of the things we discuss so often.
There's some of this I can address because, and this is so common that I need a lot of details to be able to individualize it for the specific woman. And when I just right out of the gate, hearing the age of 40, I have no idea what her actual status is, except you did mention vaginal dryness. So there is very significant lowering of the estrogen. But I don't know if she's still having periods or not. I have a lot of respect for endometriosis. We certainly wouldn't want to activate it. And it brings me back to just a couple basic fundamental necessities I find in menopause. Number one is that the job of any woman, and how wonderful that her husband is actively involved. I love to see that. It's such a great thing to team things here.
It's heartwarming.
Yes, it is. That your primary job is to identify a healthcare provider that really specializes in menopause and hormones, and in the case of endometriosis, that there's a deep knowledge base there, and experience base is the best case scenario around treating a woman with endometriosis. Now, with significant, so that's your main job. It's the job of everyone. It's to find that provider that you guys go, I trust this person. We'll figure the whole thing out together. And if you trust this person, one of their gifts and talents is going to be individualizing it for your wife. And these are always works in progress. They're always processes. And that process begins in the menopause method for us with learning a heck of a lot of information about each individual patient. We do so through very traditional means, and some are beyond traditional. For example, women in the menopause method initially meet up with a very extensive questionnaire that has a lot of questions about a female's health history and hormone balance. It gives us a lot of clues to hormonal balance in that initial questionnaire. And then we're also very curious about basic laboratory results, some esoteric laboratory results, in the sense that we're always going to ask for a sex hormone binding globulin, and always ask for 4 thyroid markers, and then, of course, mammograms and bone density reports. When we gather up all that information, here's what I always know how to do, is what's the first step? Even though, for example, in the menopause method, we got the future laid out on a roadmap with many different variables based on the individual woman. But we don't have to know everything, because always during that first consultation, we're going to know, well, what's the first step to take? And then we take that first step and we see what happens. So, for example, we always schedule right there at the first visit, 2 weeks out for the second visit. And that's going to give us enough time to see what was the result of the first ideas we had as far as what to implement during those first 2 weeks. And also in the menopause method, because that's what I can speak most confidently about. And a lot of good physicians, they're doing a very similar version of this. This is in the nurse practitioners. This is not rocket surgery. This roadmap has been laid down over centuries and centuries.
True enough.
How to do it, you know. And in the menopause method, we love to, any menopause method member, they have full access to their healthcare provider, because what we've learned is that if we have that first consultation and we set a woman on her path of 99% of the time implementing a hormone program. So she's taking hormones.
Right.
In the menopause method, they get 3 bottles and off you go.
Familiar?
with our instructions. But we want full access, so that if a question comes up for a wife and husband about what's going on, we like to hear about that right away, because we learned the earlier we deal with questions, the smoother the whole process goes, which is much more fun. Now, I know I'm staying general, but I have to. And here's something about endometriosis. We certainly don't want to activate the endometriosis.
Right.
I don't know the endometriosis status in this gentleman's wife. Like, what does she has active implants? Has she had surgery to remove implants? The one thing, like, for example, in a menopausal woman who's no longer having periods, if we give her an overdose of estrogen, she's going to form an endometrial lining, because that's what estrogen, one of the many things estrogen does. And if we give her way too much of an overdose, she's going to bleed. She's going to do a pseudo menstruation there.
Yeah.
Because what we stimulated was too much of an endometrial lining growth. So in a woman with endometriosis, one thing we're going to want to avoid, of course, we want to avoid this 100% of the time and 100% of the women. We don't want to go into estrogen overdose. We don't want to activate the endometrial lining of a woman with endometriosis, or we don't want to activate if there's endometrial implants outside of the uterus going on, which is what endometriosis, one of the hallmarks of endometriosis. We don't want to stimulate that.
No.
So with a woman, and here's the thing that I've illustrated before. Young women vary as to how much, let's just single out estrogen, they need to go through a normal menstrual cycle. They're very individual to individual. Some women need figuratively this much. If they go below this much, they don't have that much estrogen, they're not going to get a cycle.
Right.
They're not going to menstruate. They're not going to form an endometrial lining. The breast isn't going to undergo. No, some women need this much, sort of metaphorically. Other women, they need this much. And all women who are having regular periods and are fertile, they're falling somewhere in this zone. That's a pretty broad zone. In other words, some women are perfectly healthy with this amount of estrogen. Some of the women, to be perfectly healthy, they need this amount of estrogen. And then women vary woman to woman. Well, what the menopause method has determined is, for women in menopause, we do not need to have women in this zone. We're dealing in this zone.
Right.
Right below, actually, the amount needed for a young woman to have periods. And so the hormonal ranges that we're treating a woman with are so less likely to activate endometriosis because we're not dealing with youthful levels. Now, that's not the only moving parts with endometriosis. I have full respect for that. So, yeah, nice idea. We're going to treat with less than young women, but at the same time, we're going to pay very close attention. For example, the women with endometriosis that I've had as patients, if something goes off, they feel it. It's called pain.
Yeah, that thing.
That thing.
Yeah.
And so we're going to pay close attention, even though theory says we're not going to be activating their endometriosis. We're going to come up with our idea, and then we're going to see how it plays out. And if it begins to get a hint of activating the endometriosis, we're going to back up and figure out what we need to do. We're certainly going to come in with robust progesterone, which suppresses the effect of estrogen. Oh, yeah. We can really go wild with progesterone, so to speak. If we go into overdose in progesterone, a woman will be groggy. So we back her down from the groggy dose. Or if she's just taking it at night, if we go into overdose on progesterone, she's going to wake up groggy like she had taken a sleeping pill. So we're going to back down the nighttime dose. But we're going to get really robust on progesterone to suppress or to balance out the estrogen. So again, primary job with endometriosis, find someone who's knowledgeable and experienced. And they're going to work the moment to moment of it with you.
Mm-hmm.
That's what good providers do.
Mm-hmm.
They learn a lot. They design an idea how to proceed in the world of hormones, for example. They administer hormone dosages.
In menopause land.
Yes, in menopause land. And then they're going to pay a lot of attention. They're going to want to stay in close communication with you to make sure that the idea plays out. And yes, with endometriosis, that it matters all the more. And here's what I've discovered about medicine in general. There's always a path.
Yeah.
Healing is possible. Sometimes the processes take more time, have more ups and downs to them, take more testing and trying this idea and trying that idea than you'd ever want to think you'd have to go through.
Right.
That's not the most common thing that happens in menopause, and it does happen. It definitely happens. So, yeah, don't be surprised if you don't have a process. We have a contract that we sign with every woman, and the very first, I believe it's the first paragraph these days, says menopause treatment is a process. We will take time over the course of the first year. The nice thing is that once a woman is deeply into menopause or into menopause deep enough, and her initial program is tweaked, it doesn't change very much over the years. It gets very simple at a certain point.
Yes. Yes. You're right.
So,
And
but it takes the tweaking, and sometimes there's patients that have complex issues, but healing is possible. And so we just take the time and figure it out.
time being the operative word, kind of.
Yeah. So, yeah.
Well, you know what? Thank you for that answer because yeah. Thank you for that answer.
And there is one more thing I'd like to say. From what I was able to glean from the question that was asked, it sounds like they have a caring provider that's proceeding with step 1, step 2, step 3. I could understand that a husband and wife involved here can feel confused, and at the same time, the thing you don't want to be confused about is that you have trust of the human being that is your healthcare provider, that they're working with you. That's the part you don't want to have be confusing.
Right.
And if you need to do some communicating and say, gee, I'm so grateful. This is going really well. I really trust you a lot. Or you need to say something like, I'm a little uneasy. My wife matters greatly to me. And I'm a little nervous about this process because I've seen her over the years have some major troubles. And my hope is that we'll pay such close attention. What's the husband doing there? He's communicating directly with the provider. And with endometriosis, and with many different instances, probably all of them, okay, you go down the skinny branches, you take a risk. You're communicating to a healthcare provider, and yet it's something you want to know pretty early on, because you want a healthcare provider that's going to listen and want to address your concern as a husband. And if you're having trouble getting the question out of your mouth, you want to respect that, because you want to, what's the matter? You're afraid to ask the question. Maybe it's because you are genuinely concerned, and you take the risk and you ask the question. And if you get someone to bark at you, well, you might as well know it early on, because your job will then become, well, let's go find somebody else we trust who really knows what they're doing here. And as a husband, I promise you that that's one of the most important things with this process and with your wife. With a good process, there'll come a time where you're not going to have to think about the details. Your wife's going to be happy. She'll be figuring it out. Yeah, she'll be involved in the process, but you'll be able to be at peace. And if you're not at peace, husband, let's respect it. Let's kindly and as politic as possible, because sometimes we're human beings, and sometimes we physicians, particular, have this issue called they don't like to be challenged or communicate. May you not have to face one of those, but you want to flush these folks out in the open. You want to, even if it feels like, oh God, I'm feeling uncomfortable about how my wife's being treated. Oh my God, I'm going to have to speak up here. I'm going to show up at that visit. Oh my God. And I may have to face some opposition there, but go ahead and do it. Go ahead and do it. Show up at that visit. And if you feel uncomfortable, respect it.
Isn't it called like that stretch?
It's called a stretch. Yeah. And the general process is, if you're uncomfortable, you want to flush the situation out into the open by communicating as kindly, as carefully as you can, and communicate. And what you're going to find out is you're going to have a healthcare provider that is really grateful to have you along for the whole journey. They realize that the participation of a husband can be so beneficial and so supportive to the wife, and that a really good doctor is going to, or a nurse practitioner is going to want to, is strong enough and has got the guts and the ovaries and the testicles to sit there and listen.
I haven't heard it put like that exactly, but I like that one.
Sometimes that's what's called for.
Oh my God, that's hilarious. I love that. I'm gonna write that down.
They're going to want to listen. They're going to invite an active process. Yeah. They're going to be used to communication by the people in their lives that are close up and personal. They're going to be used to being stretched. And, all of us, when we get stretched, it can be a, do I really have to go to this place of discomfort?
No.
So yet again, a minor question without much to be concerned about. But it's important. It's an important thing, and it really takes where the rubber meets the road. Is you're a husband with an actual wife who's actually facing a challenging situation. She's had endometriosis, so health has probably been an issue for her for quite a while, and you want to get it right. So jump in and participate further. When I see a husband in a consultation, my heart warms up.
Absolutely.
I go, this woman has got a partner, and they're best friends, and they're going to figure this out together. So, but at any rate, don't be afraid to ask the questions. Ask them. And what's the worst case you're going to learn? You're going to learn you're facing something that you don't feel is a team member for you. And you got to go shopping. And that's the worst case scenario. You have to say, well, it's been nice working with you. And I wish you the very well. And by the way, I'm not feeling like I'm going to get the kind of care that I care about from my wife here. Just to let the office get a little feedback. or you tell the office manager there. So that we don't get unfeedbacked. And then you go out and you do the big job, which is go shopping. There's thousands and thousands of skilled, experienced healthcare providers that really care about treating women in menopause properly. And
many of them whom you have trained yourself, Dr. Rosensweet.
Yes, we're part of that, and that's one of our main functions, actually.
There's a huge backstory one day we'll get to in regards to you and where you come from in training the first 5 nurse practitioners ever on the planet. I mean, it's really deeply, deeply appreciated.
I know their names. They were amazing human beings. There were 6 of them, and they're amazing human beings. But I think we should probably go on to the next question, or I'm just going to wander off into oblivion.
The next question, though, oddly enough, still happens to go on to today. We have like Testosterone Tuesday or whatever. Today's turning into Endometrial Day, because this question says, and I like this question, is it necessary to bleed every so often, not like, every single month or anything like that, but every so often to keep the endometrial lining from thickening? I am postmenopausal, and it occurred to me my endometrium could be thickening. So when we're menopausal, what happens to it when we're post and on hormones the rest of our lives? Like, does it just stay there, disappear? Should we bleed?
Good segue. I see what you mean there.
Yes.
Well, in order to actually form an endometrial lining, once again, although the amount of estrogen needed, this is representing the amount of estrogen needed, this would be 0, this would be a bunch. Women vary. Some women need this much to form an endometrial lining each cycle. Some women need this much, and every woman falls within sort of this range. Well, 99% of the women, from our perspective, we're not giving them that much estrogen. We're giving them this much, because that's all it takes for 99%. Notice I'm not saying 100%. 99% of the women are going to get what they need. They're going to get vaginal health, bone health. Arteries are going to be supported. Brain's going to be supported, even if there's cognitive issues. And all the myriad of things that estrogen, progesterone, and testosterone do. And it's very critical that we get enough. We want to protect those muscles with adequate testosterone. Oh my God, do we want to protect those muscles? We don't want people to have to go into canes, walkers, and certainly not wheelchairs if it's avoidable, and it is, by just getting the testosterone right. We want people to sleep right and have good mood and produce new bone, which is what progesterone, 3 of the multiple functions that progesterone does. We want to get the dosages right. However, they don't require youthful levels.
Right.
So in order to form an endometrium, this zone is not where we're playing. We're playing in this zone.
Yes.
Now, for years and years, we did something called a transvaginal ultrasound annually on our menopausal patients, because we wanted to look at that lining of the uterus. We wanted to see what happened to it with the doses we were given. And there's guidelines that are excellent guidelines that gynecologists use all the time. Some of them don't like to see an endometrial lining thicker than 3 millimeters. Oh, that's between my fingers, thumb there. Excuse me, I'm gonna sneeze. Excuse me.
It's a collective Gesundheit.
Thank you.
You're welcome.
Some gynecologists, radiologists will hold 5 millimeters. I'm not exact there, but it's between my thumb and my finger is the amount, the thickness. And that thickness will stay stable for years and years and years on the estrogen doses that we're actually giving. Occasionally, a woman gets a thicker endometrium than that. We're not interested in that. We start asking the question, does she have sufficient progesterone to suppress that endometrium? Because that's what that progesterone will do if it's present in adequate dosages, and we'll make a dosage adjustment. But bleed, no, we're not. We don't want a menopausal woman to bleed.
Mm.
We don't want a menopausal woman to be forming a significant endometrial lining.
Mm-mm. Well,
we want it to be a thin endometrial stripe that is non-active and does not need to be shed. And so we know the dosages that are common to prevent that thickened endometrial lining, and we stay shy of them. Now, occasionally, in order to alleviate symptoms, we got to get into much more robust levels, and sometimes we'll see spotting and bleeding, but it's not our ultimate goal. And if we see spotting or bleeding, the first thing we're going to do is reduce the estrogen and/or increase the progesterone. And spotting and bleeding is common in the perimenopause and early menopause, especially when we're replenishing hormones. But ultimately, the goal is to not form a thickened endometrial lining and not spot and bleed. And we pay attention to that spotting. You know, if a woman's been on hormones for years and all of a sudden she starts spotting, we're going to do a 24-hour urine hormone test on her. We're going to drill down on the symptoms that she's having. And right around the corner is a visit to your friendly neighborhood transvaginal ultrasounder.
Ultrasounder, yes, it's a new profession.
Otherwise known as your gynecologist.
Correct.
Or your local ultrasound lab in your hospital.
Right.
Because it's a relatively non-invasive. I mean, who wants to go do a test of any kind? But it's relatively non-invasive. It's certainly not painful. And it gives us terrific results. We get to look at that endometrial lining. And that spotting, because I'm a medical doctor and I care about the whole range of possibilities, when I see spotting that hasn't been spotting, I'm going to pay attention to it, and I'm going to want to know what it's about. And especially if a woman hasn't had any kind of hint of bleeding for years and now she's spotting, because in the course of 25 years of treating women in menopause with bioidentical hormones, we pay a lot of attention to spotting that comes in out of the blue. And I've had 2 cases of endometrial cancer. And we caught it early. And yes, it required a hysterectomy, but the cure rates on this are near 100%. So we pay attention to that spotting. It's rare, but it exists, and that's one of the things about we want to consider all possibilities. Very often in medicine, and so many different times in my career, I've asked this question myself. Well, we got a symptom here or a sign that I don't know what the significance of it is. So I ask myself the question, okay, what's the worst case scenario? What could this symptom represent that if I missed it, if I wasn't paying attention to it, there could be an untoward outcome? So I'll ask myself that bottom line question. So whenever, I don't like to scare anyone, but I like to be thorough. And my training is that when you don't know, you find out. And when I can't explain readily what that spotting's about 2 years into treatment, I want to find out. And we got wonderful tools that have been around for a long time to find out about spotting. Now, I did mention 99%, and I did not say 100%, because some women, and I've told this story before, their cognitive challenge, their ability to think and remember and function in daily life with their minds, so many of them who go into menopause and have minor or moderate cognitive challenges, it's alleviated once we get them on a proper, well-balanced, adequate, tested hormonal program, but not all of them. For example, I went into the medical literature and I extrapolated from the medical literature and applied it to the 24-hour urine hormone test. What's the minimum amount of estrogen that we're going to not want to dip below? And it was easy to, because the scientific research is there. And we want enough minimally to protect the vagina and the bones. And you can't necessarily see without sophisticated testing what the bone health is, called the bone mineral density test. But in order to have decent bones for most women, you have to have vaginal health. You don't have to have youthful vaginal health, but you've got to have a good measure of vaginal health. And it's one of our markers that we trust greatly, that a woman has enough estrogen, and of course testosterone and DHEA can play into vaginal health, but principally it's estrogen. She has enough estrogen to have good vaginal health. And there's ways to determine that, especially intercourse, for example. If it hurts, or you're dry, you don't have sufficient vaginal health, and you can recover by a proper treatment program. We define the bottom line on the 24-hour urine hormone test by a woman having sufficient potent estrogen to produce vaginal health and bone health. We know what that number is. Just to play with numbers, a woman's got to be excreting at least 8 micrograms of the sum of estradiol, the most potent estrogen, and estrone to have vaginal and bone health, at least. And we measure that, and so it's great to see that. But notice I didn't define, and I would have liked to, sufficient estrogen to protect the brain or recover brain function, because it's well known in the medical literature, and anyone who has experience in treating women, is that some women need more estrogen to recover brain function. And some women need a lot of estrogen to recover brain function. And if they have cognitive challenge and we're increasing their estrogen dose, and what would be a optimal zone of estrogen, if the cognitive challenge does not yield, we keep going. We keep raising that estrogen dose, because there's a certain number of women that just raising that estrogen dose high enough is going to restore full brain function. And that is so rewarding. It's so dramatic. It's so rewarding that we keep going there. Now, some of those women are going to get a period back.
Yes.
And they're going to get breast glandular cell proliferation.
Yeah. Risk benefit?
That's the word. What's the risk versus the benefit? Well, the great news is we can manage the risk. We can do mammograms. We can do thermograms. We don't do thermograms to screen for breast cancer. No, 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 no. Yes, I know you would like to, but it doesn't work for that. No. But thermograms have their own value. And that is they can detect inflammation in the breast, and we can do things to offset and eliminate inflammation. But mammograms, although they're not 100%, they're great. And the radiologic techniques these days, oh my God, they're even more sophisticated than a good mammogram, which is very good. So we can monitor potential risk. We can do annual transvaginal ultrasounds on women that are doing robust youthful levels of estrogen. Now, having said that, the topic that I singled out where we may need more robust estrogen levels, even to the point of where a period is restored. That topic is called cognitive challenge. And at the end of cognitive challenge is dementia and even Alzheimer's dementia. So this is a field that is not totally covered by hormones. It is remarkable how many women will get just beautiful cognitive function back simply by getting the estrogen dosages correct, even if we have to go rich and robust. But there's a Dr. Dale Bredesen, for example, who's written a book on Alzheimer's and the prevention of Alzheimer's. And he talks about 36 factors or something like that that can relate to cognitive challenge. So I never want to oversimplify cognitive challenge / dementia by saying it's all related to hormones. It's not. But sometimes you get what you want from getting the hormones right. But you wouldn't want to leave out the other stuff as well. So I'm walking deeply into the deep water, and loss of brain function is deep water. But the great news is there's so much known these days. So there's functional medicine healthcare professionals who have taken this one on as what they love to do and specialize in. And if there's significant cognitive decline, that's who you want to go to. Someone who, and the magic word is Bredesen. If the provider says, when you mention the word, have you ever read Dr. Bredesen's book? This is the only response that you want to hear. Oh, Dr. Bredesen, yes, of course I have. They're the state of the art.
Right.
They better be saying that. And if they're not, you got to go continue your shopping job.
So if they say who?
Yeah, right. If they say who, that's the wrong response. They may be an excellent, wonderful healthcare provider, but who is not the correct response.
Sorry.
So I don't want to oversimplify cognitive challenge, but I do want to say that so much can be done. And when I said 99% of women are going to be served by significantly lower levels than a young woman needs to menstruate.
Well,
you're not going to menstruate.
Yeah.
But some women, there are exceptions that we really want to go robust, even to the point of restoring a period. And what does it take to restore a period in a woman who's no longer menstruating? Or what does it take to keep a period going in a woman who's perimenopausal age? Now hear this. We've got to administer estrogen doses that are 3 to 8 times the upper limit of normal. 3 to 8 times the upper limit of normal of a 20-year-old to get that period to keep going or to restore a period. But again, if the brain is at stake and the robust estrogen will do it, we just keep going and we just increase our monitoring techniques of breast and uterus.
So, God, yeah. Well, wow. Another deep learning experience from dear Dr. Rosensweet. It's amazing to me that really with this question and the first question, how much we've learned about all the moving parts behind being a doctor, studying all of this out, being a professional, getting a transvaginal ultrasound, and, right? You can't, just glibly say, go take this or that. You must fill out that questionnaire. Get with that good doctor. Thank you for that answer. I see the, questions that are coming up behind that, and I've got my work cut out for me.
There's a question that has popped up here that I'd like to address, if it's okay, Carolyn.
Sure. Would you like me to read it?
Yes, from Antoinette.
Oh, yes, Antoinette, we do know. And she says, and good morning, Antoinette and everybody else. What does Dr. Rosensweet think about bioidentical biased and testosterone with a delivery base of a Vaseline type substance that makes it stick to the mucosal lining more? I don't know the name of it, but has he ever heard of it?
Well, the good words there are biased and testosterone. Just using the word biased means the provider who's writing those prescriptions has done some work
Mm-hmm.
and has learned about estrogens to the point where they're prescribing bias. That's the good news. Now, these ovarian hormones, testicular hormones, they're called steroid hormones, and they are fat soluble. They're not water soluble. When you eat a food that has B vitamins in it, they're water soluble. They dissolve into your system just so fast. It's wonderful. And if you take too much, you pee it out. But that's not true of these steroid hormones. They're fat soluble. In fact, when the ovary puts out, or the testicle puts out steroid hormones into the bloodstream, there is an extremely sophisticated method of transporting it around in the blood because it doesn't dissolve into the fluid portion of the blood. It has to be carried, hand delivered by carrier proteins. It doesn't dissolve. It doesn't dissolve in the blood. And when pharmacists make up these bioidentical hormones, they can't put them in water. They can't take the hormone powder, because that's what the hormones come as, and put it into water. It will not dissolve.
Kind of like an oil and vinegar thing?
Yes, they will not mix. They will not dissolve. It's kind of like if you sprinkle sugar or salt into a glass of water and you stir it up, the crystals of sugar or salt, they're going to disappear. They're going to dissolve into that water.
Yeah.
However, if you put little pebbles into the water and you stir it up as much as you want, it's not going to dissolve. Or if you took little tiny chunks of butter and you put it into the water, that butter is never going to dissolve. You're always going to see these globules, or like you were hinting at, olive oil. You put olive oil in a glass of water and you stir it up like crazy. It's not going to dissolve. You're going to still see olive oil floating around there. Well, steroid hormones, they don't dissolve. So you need to use strong solvents if what you think is necessary is to get it into solution. And for any kind of delivery method to get the same dose to pop out each time, of whether you're using a spoon or a toppy click or a syringe or whatever you're using, you've got to get those steroid hormones into solution. So you got to use solvents. So then the question is, what kind of solvents do you use? Well, if you're rubbing stuff on the skin or putting it in the vagina, again, I'm not an advocate of putting it directly in the vagina, with certain exceptions. But you don't want it to stick to the surface. That's the last thing you want it to do. You want it to dissolve into the skin or into the vagina. And so compounding pharmacists have got a real tool bag of many substances that they can put the steroid hormones in to dissolve it. You want something that actually, when you rub it on the skin, for example, it doesn't cling to the skin. It absorbs really quickly. So you put it on your skin, you rub your forearms together, for example, you put it on your forearms, not on your sport jacket, but with a shirt underneath it. No, right. I wouldn't want to apply my hormones there.
No.
I want to roll up my sleeves and expose bare skin.
That's funny.
When you put it on your skin, you want it to be, you want it to absorb really quickly. And that's the mark and measure of some of these things that they use they're called vehicles or bases, what they put the hormones in to get them to draw up. So you would not want a Vaseline type substance to stick to the mucosa surface or the skin. No, you'd want the opposite of that.
Right.
You want a kind of substance that absorbs up really quickly. Now, having said that, so the answer to Antoinette's question is Vaseline types stick to the mucosal lining. No, you want the opposite of sticking to the mucosal lining. And, interestingly enough, almost no matter what you put in the vagina, you think it's going to absorb, but all the way in the vagina, but it doesn't. So even if you put the hormone in a very absorbable type thing that ordinarily absorbs really quickly, let's say you put estriol, for example, in a special vaginal cream or gel, and in fact, you'd want to use a non-astringent one. So the Vaseline, I get a little nervous when I think about could Vaseline be astringent, otherwise known as irritating. You don't want to irritate skin or vaginal mucosa, which is even more sensitive. You want it to be taken up into the body totally. You don't want any of it residual in the vagina. Well, there's a side story showing that that's not that easy to find. And we did a test on a woman who was in her late 30s. She had a early menopause, and she had vaginal atrophy, and she loved her husband, and they were having intercourse, but it was too painful. So we wanted to give her some vaginal estriol while we were waiting for her systemic transdermal estrogens to take effect. And we had a daily application of estriol because that's one of the healthiest things for the vagina. And we had her apply it every night before she went to bed. And then we wanted to do the 24-hour urine hormone test. And the suspicion was, because it was always thought traditionally that things that are absorbed in the vagina, they absorb really quickly and really thoroughly because it's a mucosal surface. Theoretically, it should absorb faster and better. And so we wanted to do a 24-hour urine hormone test. And this woman was of scientific thinking mind. And she said, well, shouldn't I stop the estriol because the vagina holds the tube that empties the bladder called the urethra, and the urethra empties into the vagina. So we wouldn't want any residual estriol, would we? Because it went in the vagina. And well, theoretically, I could have said to her, well, no, the vagina absorbs stuff so greatly that it won't matter. Just stop it. Don't put your night before estriol dose in because it absorbs so great, and then you'll start collecting the next morning, so it won't be there. No, I didn't say that. I thought it was a very astute question. This happened a long time ago. And so I actually talked to the lab director, and he said, yeah, that's a good point. We don't want any lingering estriol in the vagina. Why don't you have her omit her estriol for 48 hours? Well, this patient decided to omit it for 60 hours.
Right.
Better. And we did a 24-hour urine hormone test on her, and her urine was loaded with estriol, meaning that it hadn't fully absorbed.
Isn't that interesting?
After 60 hours.
Wow.
So because the 24-hour urine hormone test is so crucial, and did I say so crucial? Did I mention that it was so crucial?
Something you said about crucial.
Yeah.
I think,
so yeah. To do a 24-hour urine hormone test. Well, at any rate, there is residual in the vagina, even with these carriers that are specially designed to absorb. So now I want to cut to what I've spent the last 15 years of my life treasuring. 15 years ago, my compounding pharmacist, instead of sending my patients biased to the patient directly, they sent it to the office by mistake. And I had been treating women in menopause for 10 years, and I had never seen a hormone. And here arrives this white cosmetic jar, because that's how it used to come in those days. And it's labeled biased, and I broke the seal because I so much wanted to see what a hormone looked like. And I opened that up, and this strong odor came out. And I knew what that odor was. I knew it was the carrier, the solvent. But I wasn't excited about the strong odor, because I've always been a holistic doc or a functional medicine doc for over 50 years. And I know that solvents have toxic potential. So I did some research on the solvent that was being used, and indeed the medical literature showed that it had toxic potential. And I also learned that what was in that jar, 99.3% of it was the carrier, the carbapol in that case. Only 0.7% was actually the actual bias. And I did the math, and I realized I was asking women to apply a quart per year for 10, 20, 30, 40 years. Apply something that had toxic potential to their skin and absorb it into their body. And here I am, for the 35 years preceding that magical day, I had been dealing with toxicity in patients. Some patients, toxicity is not an issue, and their desire to recover their health. Sometimes toxicity is an issue. And in all of us, I'm talking 100% of us, human beings walking on this earth, our toxic exposure is outrageous. And because it's not like arsenic, where you take a little vial of arsenic and you leave Earth because it's a little too intense, these poisons are molecule by molecule.
Yeah.
And you don't feel them come in, but they add up. And it's appalling how much they add up. And Dr. Lindsay Berkson, if you haven't met up with her, she's written books on this and how it affects the estrogen receptor sites. There you go, the story of toxicity is long and deep, and sometimes we're dealing with toxicity in patients, and that's a challenge. Because what do they bung up amongst other things besides the brain? They bung up the brain. The brain is loaded with fat. It's mostly fat and water. And these things are fat soluble, these toxic solvents. So although the dinosaurs were eliminated by a crater, they're still out there haunting the living fuck out of us. Because they became the petroleum that's and Vaseline's a petroleum derivative, as are thousands of these solvents that they put on the food supply in herbicides and pesticides. How much dinosaur does it take to kill an insect or an herb? These are pretty hardy creatures.
Not to mention huge.
Yeah. Weeds and insects, they're pretty hardy. You don't get to kill them with just angel dust or fairy dust. You need some whopper of a dose of these things. So they pretend that these things that they're putting on agribusiness food in herbicides and pesticides, well, you can't see it. So what could be the problem? Yeah, when we test people, we see it. We see it in your body. There's laboratories in the United States where all we have to do is submit a blood sample or a urine sample or even other types of samples, a fat sample, and man, we see chemicals galore. And they're testing breast milk in babies, cord fluid. These herbicides and pesticides and these chemicals, they're all over your house if you haven't gotten rid of them. So it's a big deal. So when my son and I saw what these hormones were being carried in, we went to work And we came up with an certified organic oil base. Now, there's no solvents in there, so what do you have to do? You have to shake the bottle before use, right? This many times, you're done. Turn it upside down. Out comes the certified organic oil base to carry these hormones. So that really matters. And Antoinette, I know is a long answer, but what I'd like to see you on is a certified organic oils base that anyone can access. They can contact the Menopause Method. There's 30 pharmacies already dispensing this stuff. And we're hopefully lining up with a national pharmacist also that's going to dispense this stuff. So Vaseline.
Mm.
If Vaseline was the only substance Earth I had as a carrier, I would use it.
Well, yeah, but
if it was the only substance on Earth that I had. But I'd probably use butter before I use Vaseline.
I was just gonna say, I mean, I had to put Vaseline on my face to retain moisture when I had a procedure done. And that was creepy, gross, and so uncomfortable. Like,
and yet it's common, so I'd understand why she'd ask the question.
Absolutely.
But and actually, we want certified organic oils. And if you contact us, we can give you clues on how to get them.
Yep. And I can give you clues as to how to get with you. Right?
Yes, absolutely. Through ins and outs of menopause.
Absolutely. With Dr. David Rosensweet. It's a shared experience.
Yes,
and a good one. So we're at the bewitching hour. I have 2 minutes left.
You know what, Carolyn? As usual,
it's that
time to wrap. I won't be able to do more questions today.
That's okay, because we're not at a loss for
we got Thursday,
and we've got Thursday. So God bless you, Dr. Rosensweet. I hope that the rest of your day goes absolutely beautifully. Thank you to all the women for coming in for that great question from the husband of the woman of the, let's welcome more husbands in and treat them too if they need it. Right? Okay, so signing off for today. Enjoy, and we'll see you on Thursday.
Bye-bye.